Hello, everyone, and welcome to Talk Nerdy. Today is Monday, June 20th, 2022, and I'm the host of the show, Cara Santa Maria. And before we dive into this week's episode, I do want to thank those of you who made Talk Nerdy possible. Remember, Talk Nerdy is and will always be 100% free to download, and that's because I rely on the support of both my advertisers and individuals just like you. I sound like public radio right now, don't I? But it's true. It's true. Our model is that I want this to always be free. So the best way to make it free is for people who can afford to pitch in to help offset the cost for those who can't. And so far, it works. And I just really, really am grateful for all of you who want to contribute. If you do want to contribute, you can visit patreon.com/talknerdy. You can contribute on an episodic basis, and you will get all of the love and admiration from me and some additional perks like ad-free episodes. This week, I want to thank Daniel Lang, David J.E. Smith, Mary Neva, Brian Holden, David Compton, Dudas Infinitas, Gabrielle F. Jaramillo Gonzalez, Joe Wilkinson, June Sapara, Leonard Prince, Pasquale Gelati, and Ulrika Hagman for their support. All right, let's dive into this week's episode. It's one that's really, really near and dear to my heart. And you've heard me talk about this a little bit on the show, but as I'm continuing my training and getting closer and closer to my PhD, I am focusing more and more on psycho-oncology, so providing psychotherapy to individuals who are dealing with cancer and other life-limiting illnesses, and also working on end-of-life issues. And that's why I think this episode was such an important one for me. So I had the opportunity to sit down with Dr. Natasha Datoo, and she is an expert and a provider in pediatric palliative care at Canuck Place. Canuck Place is North America's first children's hospice, and they provide interdisciplinary specialized care to over 800 children living with life-threatening diseases. So that's what we talk about. We talk about pediatric oncology. We talk about pediatric palliative care. We talk about the way that our society thinks about these concerns and the ways that we can do better. And it's just a really important conversation. And I know for some people, it can feel like a lot. It can feel like I don't want to face this or I don't want to think about these things. But I promise you, it is not just depressing. It is not dark. It is life affirming. It is important, and it can actually help a little bit to kind of go there, especially for those of us who struggle with fear around life limiting illness and death, as you will see. So stick with us. It's an important episode and provides an awful lot of food for thought. And for me personally, an awful lot of depth, meaning, and surprisingly life-affirming beauty. So without any further ado, here she is, Dr. Natasha Datoo. Well, Natasha, thank you so much for joining me today.
No problem. Thanks for having me. I'm super excited.
Me too. You know what, when I heard about you and your work, and I was, building out the calendar for this year for Talk Nerdy and thinking, who will we be talking to? What will we be doing? Your info came across my desk, and I was so excited to talk to a pediatric palliative care physician and somebody who works in oncology. And I'm going to selfishly tell you, it's because I have been I was a science communicator for many years, working as a neuroscientist. And then I went back to school later in life. So in 2017, how old was I? Well, whatever, it doesn't matter. At 34 or something. I'm 38 now, and I'm almost done. I have 1 year left of my PhD in clinical psychology, but I specialize in existential psychology and psycho-oncology. And so I see patients who are dealing with cancer, but they're usually adults, not kids. And palliative, I work so closely with palliative care, with physical medicine and rehab. And I feel like this is an area that's so important to talk about because, number one, when people think palliative care, they think hospice. They don't even know what the word palliative means. And I just think it's important for us to really dive deep into what you do, why it matters, how important it is, and what it all means. So thank you for being here, is what I'm trying to say.
No, thank you for having me. It's so refreshing to hear other people who kind of understand palliative care and feel that it's important because it's so much more than I think what the general population knows of it. So I'm really excited. I think the timing's perfect for me too.
Yay. And so when I think of the word, palliate, palliative comes from the word palliate. That's to treat symptoms or reduce pain, right? Like when we're talking about palliating something, it's to focus on symptoms, not necessarily curative. Like your job, let's say with a cancer patient, your job is not to attack the cancer. It's not to develop an oncological protocol. That's the oncologist's job. But your job is to think about all the other stuff they're dealing with and help them feel better during their treatment.
Yeah, exactly. It's funny. It's like I think a lot of people use the word to palliate as a verb, or they use, you know, I hear lots of my oncology colleagues say palliative chemotherapy now. And I think in their mind, it's quote unquote non-curative chemotherapy or non-curative
Oh,
treatments.
yeah.
And it's funny, I was just having, I was lucky enough, I was just in Italy for a conference with three of my palliative care colleagues. And we were laughing because we were like, we got to take the word palliative back. Like people are just using it in a different context than we used to, I think. And, the actual meaning is to care for, right? It has nothing to do with goals of care. It has nothing to do with intention of treatment, whether it's curative versus not. It's really to care for. And it really means to care for a human being. And that's sort of how I see it is, I prefer saying a palliative approach to care because to me, like any person who's going through a healthcare system or any human being deserves a palliative approach to care. And that really just means not just focusing on their physical symptoms, but focusing on their emotional well-being, their social well-being, their spiritual well-being, because it's all one person, right? So it really is about a holistic approach to how we care for human beings. And I'm specific to say human beings, not patients, because I think that's a big piece too, right? You know, as a physician, I take care of patients, but my patients are human beings. So, I think the word palliative is so much bigger than I think people who haven't been involved in real palliative care or have experienced palliative care are using it right now. So it's funny you
Interesting.
brought that up. Yeah.
Yeah, and I think even beyond that, one of the biggest kind of, I guess, misunderstandings that I often see is that people equate it with hospice care. They really think that palliative care is like what is done when there's nothing left to do, when it's like, no, no, no. People require palliative treatment when they're in active treatment. They require palliative care when they have a good prognosis. Like it doesn't just have to be end of life treatment.
Exactly. And I think in pediatric palliative care, that's one of the things, and I know the adult world is very much shifting to that focus of integrative early involvement of palliative care teams. But in the pediatric world, we're super privileged, and for pediatrics, palliative care to us should start at the diagnosis of a serious illness. So at Canuck Place, we take care of over 800 families who have children who are living, right? They're not dying, they're living with a serious illness all across British Columbia. And we just aren't sure of the trajectory, right? So they have a serious illness and there's uncertainty. And how do we support families with children who are living with this uncertainty through their whole life, right? So the way I explain pediatric palliative care as a philosophy is our job is to help children and families really live their best life, their most comfortable life, their most fulfilling life as long as they possibly can. And that's exactly what we do at Canuck Place is, do we contact 800 families, all the time? No, but they're out there and they know they can reach out to us for support when and if they need us. But it's not about, death and dying is a huge part of what I do, of course. Um, but it's actually not what we do every day, right? Like when I walk into the hospice, and yeah, I'm based out of a hospice, but we care for children in any setting, in hospital, at hospice, and at home. And when I walk into the hospice, I see living, right? I see kids laughing and playing. I hear, the cooks laughing with parents and families and joking about, a TV show last night. I see siblings like running around the playground. So there's so much life in a hospice, which I think is it's actually really surprising to a lot of people. It's a happy place to be. Of course it's sad at times, and we take care of children who are dying, and the tone of the hospice changes when that's happening, but a lot of times there's joy in those places, and I see it every day, which is so amazing.
Yeah. And I even the hospital where I work, within the cancer center at least, but I think across the hospital, they actually call what we know to be palliative care, they call that department supportive care medicine, simply because there is such a stigma on the word palliative. And I love how you were saying, we've got to take it back. And of course, some institutions like the one where I work are like, okay, it's so stigmatized, we're just going to call it something different so that people
Right?
really understand that we're here to support you. We're here for, this is supportive care medicine, and it can happen any phase of your illness. But it's funny how, and I wonder why. Do you have any idea of maybe why the word palliative care has become like a bigger beast than it is and has so much kind of misunderstanding attached to it?
Yeah, I think it's really interesting because I think especially for me, I only work in pediatrics, but and in oncology, in pediatric oncology. And recently, I almost feel like it's shifted a little bit backwards in the sense that the stigma has actually gotten bigger about palliative care. And I wonder if a lot of it is, we're doing such amazing things with technology, right? Children are living longer with serious illnesses. Their diseases are being stabilized. Cancer treatments are changing, right? We have immune therapy, we have CAR T cells. We're curing kids we never could cure before, which is amazing. But we're also changing, I think, people's perception of curing things. I think the word cure is different now, and I think palliative care has actually almost become a dirtier word than it was even 5 or 10 years ago when these children weren't able to be cured with these amazing technologies. I think it's great that we're advancing healthcare, but we're also shifting death and dying, and we're making that seem to be a bad thing. And I think in society, like for example, it's funny, my husband and I were visiting. I grew up in Toronto, and we were out visiting a friend of his who has a few kids, and I think they were like 7 or 8 and 3 and 4, and they were just asking me about my job, and I said I work at Canuck place, which is a palliative care hospice, and I don't even know what I was saying, but I used the word dying, and he actually got quite upset with me and shushed me and said, not in front of my kids. And I was like, wow, like as a society, we we are so uncomfortable with talking about death and dying, like so uncomfortable that we can talk about anything else, but it's such a natural process. But we just we're terrified of talking about it, and I think that that ties into the advances in medicine, and the word palliative care just terrifying people, right? A wall goes up when I talk to a family about who we are. I'm really open, and I say, some people like to introduce us as, you say, we're the supportive care team, or we're the pain and symptom team. And that's fine. Like we do all those things, but I never hide the fact that I am part of a palliative care team. And I kind of just own it and say, look, I know what I represent to you. I get it, but let me tell you about all the things we do. Right. So I think it's important to be able to break down the stigma, to just name it and be honest about it. Because otherwise you kind of just toss it under the rug, and it's this awkward elephant in the room. And so I think like barreling through it is almost a better approach. Like that's the way I work with it, is just name it, and then try my best to ease them into, actually this is what I do.
Yeah. And it's like we can only really work person to person. Like we can't fully change society all at once. But I so agree when I think about mortality, when I think about death and dying, which for me and for you and for, I mean, anybody else who works close to the dying on a regular basis, understands that this is like, we're all going to die. Like, this is something we will all go through. It's not a failure. It's not a flaw. It's a chapter in our lives that we will all reach at some point, some sooner than others, some, for different reasons than others. And none of us knows. That's the other kind of great unknown. Like, even people with a poor prognosis, it's all just kind of a guesstimation. But one of the things I do in therapy so often, and I feel like I'm lucky because when I work with people with cancer, they're all under the sun, right? Like, it might be a pretty good prognosis with an early diagnosis. It might be a recurrence. It might be a metastatic diagnosis. It might be somebody who has quite a poor prognosis who is really starting to prepare. But we can talk about death in a free way, and I can do it like on a weekly basis and really confront these things and really make a safe space for that in therapy. And I think it's important to do that even when you're well, even when you're healthy, because it's a part of what's going to happen to all of us. It's not going to go away just because we ignore it.
Totally. And it's so interesting when you say, you're able to create a safe space to talk about it, because one of the things that I think we don't actually see firsthand, but I have such a privilege of being on the side of oncology, but then also being on the side of the palliative care team. And when I'm taking care of oncology patients as the oncologist, there's such a different power dynamic, right? You're the oncologist, right? Your job, and you're expected, especially by the families, is to give the treatment that's going to cure them, right? And there's this interesting, I do all these family team meetings, and there's interesting dynamic of you're not, the families rarely open up in that setting about their real deep down worries that their child may die, even if they're not going to, or even if they have standard risk leukemia, where this is a very curable disease. There's a greater than 90 to 95% cure rate. Their child still has cancer. And of course, every mom and dad has that fear. But compared to the child who has something like an incurable brain tumor, they all have those worries. But in that room of the oncology department, they're unable to share that. And I've had families say to me when I'm on the flip side in palliative care, like, this is the place I get to share my biggest worries, because you're not the team treating me. I'm scared. A mom said to me, I'm so scared if I say that to the family that the oncologist is going to say, well, then we don't need to give more treatment. Like, if that's your worry, right? So it's really fascinating that there's so many layers to people's hesitancy to talk about death and dying in the healthcare system. And I think it's really important that we try and shift not just human beings, but also the healthcare system.
There are sadly limitations that I don't know we'll be able to change without an overhaul. And you're hailing from Canada. I'm here, below the border in America, where we have a very broken managed care system. And so one of the biggest problems that I'm usually having to work with patients on is self-advocacy in limited time. Just, how do I have this conversation when I can see my doctor looking at the clock? I can see that they need to get on to their next patient, because, the insurance company is only going to reimburse a 30-minute window for us together. And it's heartbreaking to hear that there are so many unanswered questions. And of course, you get anxious in the room. And of course, I see patients very often dealing with this kind of feeling like they have to manage the emotions of their physicians. Like, they don't want to make their physicians sad, or, oh, I want a second opinion, but I don't want my doctor to feel like I'm cheating on them. And so, yeah, processing a lot of that is super important.
It's so important. And it's so interesting, because one of my really big interests is communication and enhanced communication between physician and families, and between teams. And communication is at the center of medicine, any type of medicine, palliative care, oncology, any type of medicine. And when you go through medical school, nursing school, allied health school, there's barely any training on communication, let alone how to deliver difficult news, let alone how to have enhanced communication about advanced care planning and goals of care. So, I think it's, the Canuck Place team developed, it's called a serious illness conversation guide. It's actually a modified version of what Atul Gawande developed with the Ariandi labs. And we actually were able to develop a pediatric specific version, and we train, it's exponentially grown. We've been training other people in the hospital. We run training sessions once a month on how to do this serious illness conversation guide. And it's actually a checklist, right? It's a checklist of questions with the intent of getting to know a family, patient, a mom and dad, on who they are as human beings. It has no agenda. It has nothing to do with goals of care. It's really about getting to know a family's understanding of where their child's illness is at, what their hopes, fears, wishes are if their child got sicker, what gives them strength. And then we're able to get to know people as human beings. And when you can actually get to know someone as a human being and you understand their worries, you can help them understand where their child's disease is at and help them plan for the future. So it's really incredible. Like the more we train people in this, different areas of the hospital are coming at us and they're saying, "We heard you do this serious conversation training," and they kind of fumble the words a little bit, and it's amazing how people are wanting this training. Like they're so engrossed in like getting the skills to be better at communicating, which is actually so amazing. But it shows you how uncomfortable people are about having conversations, let alone about death and dying, but about what if your disease got worse? What if I can't cure you? What would be something you'd want to do if time were short, right? And so it's really incredible the way that people have opened up to this idea of having a conversation about people as who they are as human beings. And I think when we train physicians, when we're doing resident training, again, it's like this idea of a palliative approach to care, right? Versus palliative care. Oh, they can teach the residents about good pain management, or they can teach the residents about, what to do if a kid's having breathing trouble, right? It's more mechanical. Whereas when I work with the program directors of different programs and the oncology trainees, it should be longitudinal training, right? Palliative care has such important skills that can be used in any, let alone any part of medicine in my life, right? My palliative care training changed who I as a person, right? It really did. And so these are skills that universally we could make better clinicians. We could make better patient care. We could do so many things if we could implement this training on how to communicate better with each other earlier on. So that's one of the things I'm really passionate about is communicating with each other. And so it's kind of a cool realm that I kind of, I think, is undervalued, actually.
Oh, it's absolutely undervalued. And it's something that it's funny because coming from clinical psychology, it's like, it's like so obvious to those of us who work in psychotherapy and supportive, supportive mental health positions within a health psychology, like hospital setting. But yet very few hospitals utilize psychologists in this area. And it's like, I would love in the future when I'm, fully licensed and I'm capable of operating sort of independently to do exactly what you said, to work with medical residents on patient advocacy, on navigating difficult healthcare decisions, on having conversations, on the things that we see firsthand because our patients go in and talk to the doctor and then they come to therapy and they're like, this is what happened. Let me tell you. Yeah. And there are just horror stories. And, I don't want to like sit here and detail a bunch of horror stories because there's so many incredible physicians who kind of understand this in their bones. And then there are other physicians who maybe didn't get this training, but are really working on improving it. But then sadly, there's, an older sort of approach to medicine, which was quite paternalistic, which was very, like you said, focused on kind of curative approaches. and not very whole person. And like and I'm just going to say this with zero factors that anybody could, what's the word I'm looking for? I'm going to mask the identities of the individuals I'm discussing.
Yes.
But I know a person who's a resident, a neurologist who's working on figuring out where they want a fellowship. And I was, of course, like, neuro-onc. And they're like, oh gosh, that's so much more training. And I'm like, just do shadowing, just see what it's like. And they shadowed a neuro-oncologist. And I kid you not, this person who diagnoses glioblastoma multiforme, right, GBM, on a regular basis, which is a pretty difficult life-limiting illness that very often doesn't have a great prognosis, does not prognosticate unless actively asked. And that was heartbreaking for me to hear. So somebody, let's say in a worst case scenario, somebody comes in, it's clear that this person does not have much time left, and the doctor doesn't inform them of that because it's too stressful to have that conversation. Like, to me, that's unethical.
It totally is, right?
And it happens all the time.
All the time. All the time. And it breaks my heart, right? Because how do you care for someone who is going to die at some point of this disease when you can't even be honest with them about what the disease is, right? Prognosticating in a disease that there are very small chances of cure is part of the upfront discussion in my mind. Right?
It's like ALS. It's like not telling somebody with ALS what the course of their disease is going to be. Like, are you kidding?
Totally. And it's, I think words matter, right? I think, I've had so many parents come to me. I did my oncology training here at BC Children's Hospital, and then I became a staff, and then I did palliative care training, and then I became a staff in both. And they literally see me kind of in the hallway, and the other day, someone said, I remember the exact words you said to me behind that curtain in the emergency room when you were the one that told me my kid had cancer for the first time, like word for word. And she replayed it. And I was like, yeah, that's probably exactly what I said to you. And so words matter, right? I can think of one of our really amazing neuro-oncologists who, we had a baby who had really awful metastatic cancer, that brain tumors that weren't curable. And, the family asked, like, how long does she have? Which is a not uncommon question. And it's true. We're all told we're never certain of time. I hate the phrase, I don't have a crystal ball.
Oh, I hate that phrase.
I hate it. I hate it. Really.
I like, sorry to interject, but I like it when I like the analogy, and I often use this, that prognostication is sort of like weather forecasting. Like, sadly, the closer you get to it, the easier it becomes. But that doesn't mean that we can't still look at a lot of different factors and make some have a general understanding. But there are error bars on it.
Absolutely. And I think, this her response was, well, I can't say anything about time. I can't tell you that she won't be here when she's 90. And I was like, yes, you can.
That's like a 0.00001 chance. Like, yes, you can.
Right. You actually, and that's like, you can. And so when we talk about prognostication, we've at Canuck Place have created what we call these zones of health. And we have this system where it's kind of like this language that we talk to each other. Like, it's about really the child's fragility and their stability. Like, how fragile versus robust are they? How do we feel their body will be able to tolerate an infection? If not, are they fragile? And then their symptom and stability. How stable are their symptoms? Do they have changes in their meds and their symptoms every day? They're unstable. So we can prognosticate based on a child's fragility, stability, and their overall functionality, right? So we've actually created these objective ways that you can prognosticate. And of course, nobody knows time. But as you say, we are trained scientifically to watch children's bodies, to watch people's bodies, right? We know that there are changes that happen as the body slows down, right? And as time gets shorter, we do have a job to prognosticate, right? It is our responsibility. It's our clinical responsibility to share what we're seeing, right? It doesn't take away hope. I think that's a huge piece that I try and teach learners is you need to give a framework, right? One, I remember one dad asked me in August of one year, will she be here at Christmas? And I said, I I honestly truly hope she will be, because I do. Even when a child's dying and the family's saying, I hope she miraculously wakes up, I can honestly say I do too. Because I do believe in miracles and I hope so. I I worry that based on what I'm seeing in her disease, what I'm seeing her eat less, I'm seeing her move slower. I worry she won't be here, right? So I wonder, why don't we celebrate Christmas early, right? There are ways that we can help prognosticate while still giving hope. And it's not false hope. It's true hope that we also hope that she makes it to Christmas. But what we know scientifically and what we know our responsibility is to say, why don't we celebrate Christmas early? And if she gets a second Christmas, amazing. But we have a job, right? We have a job to do, and that's to be honest with parents and families. And we've created these ways that you can prognosticate while continuing to give hope. But then you can also care for children and families if time is shorter, right? You can provide the right care, right? In the right setting, in the right location of care. You can
And you
talk
can
about
empower
legacy.
them. Yeah, you can
Totally.
do all of these sort of end of life psychological work that needs to be done, but you can also empower them to do the things that they love, because how do you know? Like I have a patient right now who's on a really big trip. It may be the last big trip that this patient takes, but they needed to know that to stop putting it off. And that was an important thing. Like, they're well enough now, their meds are stable enough, they're able to, change the chemo regimen so that they were able to take extra time. And now is the time to do it. And without the honest assessment that now is the time to do it, they may have missed that opportunity. And how heartbreaking would that be?
Totally. And we have families. One of the hard questions we get asked a lot is, should I should I get the grandma and should I get grandparents to come see, or should I get
Oh,
people to
right.
visit, or and really indirectly they're asking how long do we have, right?
Hmm.
Um, and one of the things I always say is, I don't think there's ever a bad time to make memories, right? There's a difference between memory making and we talk about memory making in terms of legacy items in pediatric palliative care. There's a difference between memory making and making memories. I've sort of started to shift my language to say, let's make memories, versus, again, memory making kind of has that connotation of only do it at end of life, versus making memories. We all do that. We're all living our lives and making memories as we're going through it, right? So I really think that language matters. Recently, I've started, when we were in Italy, um, out and about, and out to dinner with some wine, and we came up with this like term, because we were talking about language, right? We're talking about language, and we, we came up with this term, intensive comfort care, right? Because that's what it is. That's what it is, right? When you're in the home of a dying child, or you're at the hospice and a child is dying with really awful cancer pain and they have 6 infusions going, and you're taking care of them, that's intensive care, right? It's intensive comfort care. It's not doing nothing in any means. But I've started to use that in the hospital, and people kind of look at me like I have three heads. And I'm like, well, it is intensive comfort care,
Yeah,
right? And
you've
I
got to
can
be able
provide
to make the
intensive.
distinctions between acute versus long term, between intensive versus maybe a typical amount of attention that's being paid. Like, these words are meaningful to us as providers too, to kind of understand, how present do we need to be? I mean, we should always be fully present, but how much do we need to maybe prioritize coming around and rounding here? How much do we need to prioritize, these parents are really, really anxious, and we really need to be making sure that their needs are being met and their questions are being answered, as opposed to, this family in the room next door who's sort of, stable and okay and probably doesn't need that kind of attention right now.
Absolutely. And it's so interesting because I have such a privilege of working with these like amazing mentors who've been around for so long. And we talk all the time about the differences in cultures, like just thinking about words, because one of my mentors introduced me to Two Worlds Cancer Collaboration, which is a nonprofit organization out of Canada, out of British Columbia. And I've been an executive member for like 3 years with her. Three of us clinicians are from Canuck Place are on the team, and we're able to support building capacity and training for palliative care and pediatric palliative care in Southeast Asia. And it's so fun because we get to train. We have a fellowship training program, and it's all through Zoom. And we get to train. Right now we're training our second group of fellows on how to do pediatric palliative care in Nepal, in the Philippines, in India, and they often have such different language meaning. Like the meaning of their language is so different. And if you think it's hard to talk about dying in our society, in North American society, it's really hard to talk about it in those cultures. It's, and again, it's not saying it's this culture versus that culture. It's just a different culture, right? Dying. It's interesting because dying is it's so spiritual in certain cultures, but it's so hard to talk about in some of those similar cultures. And the fellows are so open to learning, but it's fascinating to hear their stories of, these families who, again, it's not talked about, right? And resources are very different, right? In a lot of parts of the world, which is so different and sad for me, but at the same time opens my eyes, right? I have such a privilege of seeing what human beings globally experience as part of life. And, they're taking their child home because they can't pay for the leukemia treatment. Like the child's could live if they were in Canada, but they're taking their child home. And how do you have that conversation, right? How many layers are on there about taking your child home to die because there's no resources, right? So the wording of things in different cultures, I think, is fascinating. So it's something that I'm really learning about right now, early on in my career. But words matter, and I think that's the thing that they matter just as much as surgical skills. They matter just as much as good understanding of medications and treatments. But yeah, one of the things I'm really actually super excited about is, along with words, I think understanding the competencies around what we used to call end of life care, but we're sort of shifting to call it imminent dying. Because end of life,
interesting. See, I still use end of life all the time. Okay, imminent
it's
dying.
Funny. This is a new. We're just kind of like, again, after some wine, we were brainstorming, and my amazing colleague was like, but end of life makes it seem like one time point, right? It's like end of life.
Yeah,
life is end, like it's ended, versus imminent dying is a time period, right?
True, but also there's that stigma again of like, the word dying is so jarring to a lot of people. I mean, I use it a lot. Like my whole thing is like, no euphemisms. Euphemisms just confuse things. Be very plain in your speech. And so, yes, I use the words death and dying a lot, but I could definitely see some people being like, I'm not calling it that. Like, I'm definitely not comfortable enough to call it that.
Right? It's so interesting. And so, we're sort of shifting into like, we're trying to talk about it is the patient imminently dying? And for us, it just helps us understand how we need to care for them, right? We need to think about location of care. We need to think about, counseling support. We need to think about bereavement support. We need to think about what kind of intensive pain and symptom management we're going to do. But yeah, it's funny. We were talking about end of life versus imminent dying, and we're using that more and more in our group.
How do you define it? Sorry I keep interjecting, but how do you define it? Because I often will use the term actively dying, but there I'm usually talking about weeks, days to weeks, maybe months, but really like weeks to days where you're starting to actually see physiological symptoms, or like you can see these markers of the actively dying patient.
Yeah, I think that's how I would define
And then when I think of end of life, it's funny. I think of some of the people I'm working with could have 2-3 years left, but they're still nearing the end of life and they're starting to prepare and doing legacy work and advanced directives and, all those things. So that's funny
Yeah,
that I actually think of end of life as a longer
as
period.
longer.
Yeah,
That's
that's so
funny. It's
interesting.
funny. I think in pediatrics, the trajectories are a little bit different, right? So it's,
Right,
you
right.
know, if a child is going to live 3 more years, goodness me, nobody except for us is
Is
talking about
saying
dying,
dying. Yeah,
right?
that's
Because a
true.
child's
Whereas if
life is
you're
short.
80 and
Yeah,
you've maybe
yeah,
only got a couple years left, you're
right.
dying. You're starting the process. Yeah,
Yeah.
okay. I hear
Very
you.
different
I hear you.
time
Yeah.
frames. Yeah. And, we used to talk about it as like we're doing an end of life, quote unquote, admission to the hospice versus now we're starting to hopefully say, is the patient imminently dying? What's the best location of care? Right. We're trying to be a little bit more holistic about location of care. And I think that's an important piece too. Like, we have this amazing enhanced community care program at Canuck Place where we can support families, whether they're in close to where we are or anywhere in BC, by forming these not teams of care providers who can help keep a child home if they want to be home. And that's, you know, to me, that's really holistic care, right? How do we build capacity to help a child stay home if that's where they want to stay home?
Yeah,
And
and that is more
and
common, I think, in older it's funny, like, some people go to physical hospice facilities, but I feel like every one of my patients that has died over the time that I've been with them died at home. One of them died in acute care in the hospital, but all the rest of them died at home on hospice.
yeah, it's really different in pediatrics. Like if I were
Mhm.
to think, you know, yeah, my colleague who was like around when Canuck Place was built 25 years ago, a lot of kids couldn't die at home because we didn't have the capacity, and she witnessed kind of that more and more families are wanting to die at home, and we don't have, like, for children, we don't have that type of home hospice care. So Canuck Place has been able, with donors and with the amazing vision of these colleagues of mine, have been able to develop this enhanced community care program where we essentially do provide the palliative care for children holistically at home. But again, more and more kids, truthfully, like the last 2 or 3 years, because of technology, we're pushing the boundaries, right? We're adding phase 1 or 2 trials for pediatrics now, right? And you guys see this all the time in adults, but in pediatrics, it's like we're doing things to already fragile, highly pretreated children more and more, right? And I'm not saying that that's wrong. I'm just saying it changes the scope and approach of palliative care, right? How do we integrate into that, right? How do we come in to join the team and say, okay, you're going on a phase 1, 2 trial. Really, we know what phase 1, 2 trials are. They're dose finding, they're efficacy trials. There's no intention of cure, but families are all hoping for cure in those things, right? They are, and that's okay. But
Yeah, that's
how do
why
we
they
allow?
enroll. Yeah.
Exactly, exactly. And we have standard treatments because of trials like that from 30, 40 years ago, right? They're needed, they're necessary. But how do we empower the oncologists? And that's one of my things. I love working with both teams for such different reasons. They have totally different philosophies of care. But how do we empower the oncology teams to say, okay, how do we take away their biases about end of life and non-curative intention and say, okay, this is your other team that we're just going to work together, right? And there's so much research on that, but it's really day to day. It's getting trickier and trickier, and more children are dying on the ward. More children are dying. Less children are. It's almost like when they die in the ICU, like our ICU colleagues, do involve us quite early. They're more comfortable even with end of life medications. We have a different philosophy on how we give those, but when they die on the ward, I one of the things that I keeps me up at night, truthfully, is is when a child has a death that I feel could have been better. I feel
Yeah.
they
Oh,
suffered. I
completely
feel,
agree. Yeah.
and it's one of the things that, like, even now, like when I think about it, I can think about a patient I had who, the patient was on the ward, and she was a little girl, and she had neuroblastoma, and she had a bleed, and she was there. We knew she was there for what we called at that time end of life care. And the training physician did the best they could, but they didn't feel comfortable giving the medications that we would give for the reasons we would give it. They didn't have the competencies to talk to mom and say, "This is what I'm seeing. I'm worried. I'm worried your child is dying. You need to get into bed with her. You need to hold her. You need to talk to her. You need to do these things, right? You need to be directive at end of life.
Yeah,
Nobody
it's
knows how to
time.
take care of their dying child. You need to tell them how to do that, right?" There is a paternalistic part of end of life care where nobody knows what to do when their kid is dying. You have to direct, and you have to recognize it. And so these are competencies. There are so many competencies in that period of time that could be short hours to a few days. That How do you interact with the nurses? Where do you put your body, right? Like, how do you position your body when the mom is standing at the bed and the child's in the hospital bed and the nurse is at the pump? I'm always cognitive of where am I standing? I'm often standing in the back, but the nurse can see me because I can say, give a bolus. But those are competencies that, for whatever reason, aren't taught. They're not. End of life is not seen as an acute care event. And I think that bothers me a
Which
lot.
is amazing because it's like the
It
most
bothers
acute.
me. It's the most acute,
Yeah.
right? Like, we run simulations on, anaphylaxis when a kid has an allergy. We run it on seizures. We run it on sepsis. We run it on when someone has asystole, right? Like, but why is it that acute dying is not an acute care event, right? It boggles my mind.
And sometimes
Like,
it's sadly neglected because I think people it's sometimes slow, right? Acutely dying can take hours to days. It's sometimes very quick, but sometimes it's very slow. And we see this in hospice care, right? Like education for the family about things like the death rattle or about a jolt of energy they might have right before or about delirium, but we don't really, I think, prepare until right before it happens, which it's like, no, we should be preparing for this weeks, maybe even months in advance. And also, I think there's the discomfort, you see it with residents a lot, but also even with attending physicians, there's the discomfort of just being in that space. And you can feel in the room how much they want to get out of there. And that's not okay for the family or for the dying patient if they're cognizant, if they're not, heavily delirious. Like I had a patient who just was talking up until they died, and they need somebody to look them in the eyes, hold their hands, and when they say I'm scared, sit and say I hear you, and this is probably the bravest thing you're ever going to have to do, and I'm with you, and you're not alone.
absolutely. And we're not taught how to do that, right? We're never taught, and we don't talk about dying. And there's the concept of holding vigil, right? That's real, right? When you're sitting at the bedside of a dying patient, that's been done for centuries, right? um, but I have witnessed over and over, like, if physicians coming in the room, you see their face, the patient's changing and is dying, and there's uncomfortable humor. There's, like, it's really, and that's what keeps me up at night. And so, I really feel strongly that dying should shift to an acute care event. And I like it's we're starting. We just had our first meeting about this really cool project that we're going to try and do, jointly with the hospital at BC Children's and Canuck Place, is running simulations of end of
So
life
smart.
situations, right? Like, how do you teach people? Well, you have to simulate it, right? How do you teach them where to stand in the room, what to say to the mom, when to give a
Right.
medication, how to educate on, dyspnea at end of life, and why morphine is actually helping the symptoms, it's not actually killing them, right?
Right.
All of those things that why would you know how to do that, right? When you're not taught it. So we're actually going to start doing acute care simulations on end
That's
of life.
huge. And not just in
Yeah.
palliative care or onc teams, but like ER physicians need to know this. ICU physicians need to know this. Like, this is important for people who may have somebody who comes into their service who is way sicker than anybody knew and who might die in their service. Like, people in ICU see death all the time. People in ER see death all the time. And that death shouldn't be treated any differently. There should still be that level of compassion and understanding and communication.
Yeah, yeah. One of the ICU fellows is working with us on this, and I'm just so excited about it because you know, even though the outcome of the acute event, right? If you're running a code for a cardiac arrest and they recover, versus that acute dying, the patient's going to die, but the impact of that, right, for the remaining family members, siblings, the rest of the healthcare team, if it went poorly, is huge. I've had nurses quit after deaths went badly on the ward,
Yeah, I could
right?
see
Like
that. Yeah.
it's
And
it's a
sometimes it's about too
huge.
much care, sometimes it's about not enough care, but it's like it's chaos. There's these chaotic moments where nobody knows what to do because nobody communicated it in advance, where we don't know what the advance directive says. And it's like, yeah, that's traumatizing for everyone involved, not just the dying person, who sometimes I feel like is the last one anybody is considering. This is something I worry about sometimes, and maybe it's different in pediatrics, but working with as their as their psychotherapist, I have a really different perspective where it's like, I'm here for you as you go on this journey. But I feel like there has to be this more holistic view with a lot of the providers, which is like, we're here for your family, we're here for your friends, we're here for the other providers. We're trying to figure it all out in a milieu. But I'm lucky that I get to be like, what do you want? Where are you at? I'm here with you. And I feel like sometimes the actual dying person, especially if they're delirious or especially if they're showing symptoms where they're in and out of consciousness, all of a sudden they're no longer a person. They really are just a patient. And it's all about the people around them.
Totally. And we see it often with teenagers, right? We're so focused on the parents, I find, and talking to the parents and talking about the advanced care plans with the parents. And we forget a lot of times that it's actually the teenager's body that's changing,
Right. And the
right? And
teenager has the cognitive capacity and the wherewithal to make decisions.
totally, totally. And, we recently had a patient on the ward who he he came in and he was sick and we knew he had relapsed cancer and you know he was just getting sicker. We all knew time was short, but we none of us felt it was that short. I think he had a little bit of an acute event, and his we were focused on the parents. We're all in there. There's an RT trying to get high flow on him for his oxygenation. And I actually stepped to the bedside and I said, "Hey, are you wanting to talk about what's happening to your body right now? Or are you feeling like you know what's going on?" Right? You have to ask permission, right?
Right. Or do you
And
not want to know? Because that's also, some
exactly.
people don't want to
Yeah,
know, and that's their right.
exactly.
Yeah.
Exactly. And I said, "Do you want, like, how are you feeling about what's happening? Do you want to talk to us about what you think is going on to your body? Or are you okay?" And actually he looked at me and he said, "I'm okay right now." And but you have to ask,
Yeah,
right?
because
There's
they may
this
not
all this
know.
commotion going on. I think there was
Hmm.
20 people around him doing stuff to him,
Ugh.
right? Doing stuff to him. But nobody asked him, does he want to know? Right. And I think and that's fine that he didn't, but at least he felt like he was heard. And so, you know, I think it's funny because, every time I think about how do we build capacity, and I think these simulations are going to be super helpful. I think, we keep plugging along, delivering palliative care in an acute care hospital setting is a way to get, people understanding of how palliative care can support children who are living. Um, but my husband's in my husband's in IT, and he always kind of half jokingly says to me, the robots are going to take over your job one day.
Right.
And
Yeah.
I very strongly am always like, not my job. Maybe
Right.
the
Yeah.
surgeon's job, but not
Yeah.
my job, because we are able to bring, I think that's the part about palliative care that I truly feel is special, is we come at it as human beings. we come at it with as people who, some of us are spiritual, some of us are religious, some of us are not, but we all come at the care we are able to provide as human beings, not as physicians, not as nurse practitioners, not as nurses. In those moments, we're just another human being, and I may not be able to fix it, right? I will try everything I can to make that imminent dying and that death comfortable and better as best I can, but I may not be able to take away all the suffering. And I have to be okay with that, right? That's why people run out of the room. When you can't
Yeah.
fix something as an oncologist or a surgeon or an ER doc or an ICU doc, you bolt because
Yeah.
you went into it to fix things.
It's why,
And
in a
you
way, I
have
think
to be.
as psychotherapists, we're at an advantage and a disadvantage. We are not empowered to do any of the medical stuff. So it's outside of our purview. It's outside of our training. We don't have the competency. We're not there to fix anything. And when people, talk about suffering, especially within a palliative kind of
Mm-hmm.
situation, very often what they mean is physical suffering, but the psychological,
Mm-hmm.
spiritual suffering is something that's harder to palliate because we don't have drugs for it. I mean, we have some,
Mm-hmm.
but a lot of it
Mm-hmm.
requires work, self-work, compassion, humanism, exactly what you're talking about. And we are very often tasked with sitting in that discomfort and knowing that there is nothing to be fixed. We just have to exist right now. It's not
Totally.
easy.
And it's not easy. I often love the fact that I have such amazing spiritual care counselors and counselors who I can, sit in because I learn so much. But it's also like we sit with the suffering, even though we can't fix it, but we also see miracles, right? If you're going to stick through, you're going to see things outside of medicine that preclude science. Like I think of this boy, this amazing boy who we we took care of 3 years ago for the first time. He had this horrible brain tumor. He had started radiation in the summertime for this tumor, and the second day of radiation, he had this massive bleed in his tumor, and he was herniating, he was dying, his pupils were blown, and the family said, you know, it, we want to take him home if he's going to die if time is short. They're this amazing family, right? They made caring for him very easy. They said we want to take him home. And so, our team rushed to get everything in place. To take a dying child home, you need supports. So we get all this stuff. We get meds in the home. We get people who are going to go in every day to check on him. We actually got this like urgent Make-A-Wish, so he could be in like an Airstream trailer on their
Oh,
street.
cool.
He'd
Yeah.
always wanted to be in a trailer, and so we made this happen in this weekend. and and I happened, I wasn't on call, but I'm texting over the weekend to the other physician who's on. I'm like, we send emails every time a child on our program dies. So the whole team, including, IT people, everybody who's part of our institution knows that this child has died, so they can take a moment to reflect. And I'm waiting for it. And I'm like, what's going on? Like, how's he doing? And he's like, oh, he woke up. He's walking around. And I was like, pardon? And he's like, oh yeah, he walked out of the trailer. He's loving the trailer. He's walking around. And I was like, oh, okay. And he lived 2 more years, like soccer practice, like regular, you know, 12-year-old stuff. And and how do you explain that? You can't, right? So I think there's magic in what we do. And I think, and then he did pass away. He passed away not too long ago. And the family had this amazing ability to sit with suffering and sit with the grief. He eventually lost all ability to communicate. He used to use his eyes and he used to use his one finger to point, and then he lost it. And the mom had this amazing ability. He couldn't move anything in his body to know when he was suffering and what symptom. And to sit with that, I just would sit there in the room at their home, and I mean, I couldn't do anything. He's not my boy. I'm not connected to him in that way. But to sit there with her and say, okay, we're going to sit with the suffering together, right? One of this same amazing colleague and mentor says, suffering is halved when done together, right? So if you can sit with it, that's medicine, right? you get to see the miracles, and it's huge, right? You get to see both sides of it.
It's almost like the easiest and yet the hardest thing that you can do, right? It doesn't require really any clinical skills. It doesn't require any like knowledge. You don't have to remember anything you learned in med school. You don't have to be able to calculate dosage, but it's still one of the hardest things because it requires like a deeply human capacity for empathy and for patience and for you have to have worked on yourself. You cannot do this job if you haven't done therapy yourself, if you haven't introspected yourself, if you haven't confronted death and your own fears around it. It's just something that you have to bring that to the table. And I think it's really, really important to do so. I have to ask you, Natasha, because I don't want to keep you all day, but I could talk to you about this for hours and hours. There's so many things we haven't even covered.
Me too,
But
totally.
have you seen the documentary? And I bring this up because I think a lot of people listening, unless they've personally been through a terrible pediatric situation like this is conceptual to them. It's like we can think about it cognitively, but emotionally we may not have been touched by it. But there's a documentary which gets you a little bit closer. It's hard for some people to watch. I found it really impactful, called A Lion in the House.
I haven't actually watched it myself yet. It's on like my list.
Oh,
but
I highly recommend.
actually.
It's stunning. And I've known oncologists and physicians who were like, I couldn't watch that because I don't work with kids and that's too hard for me. But it takes place it's long. It's 225 minutes. So you can break it into pieces. It took 8 years for them to make it. There's some longitudinal following. It follows these kids at Cincinnati Children's.
Yes.
And many of them die. And there are beautiful, meaningful, just stunning moments. There are very hard moments. And one of the ones that sticks out the most to me is a child who was a teenager. I think it was a lymphoma diagnosis with multiple relapses and or maybe it was a leukemia diagnosis. No, it was lymphoma, and ultimately did die. But it was that situation where it was imminent, and it was very hard for the parents to understand that it was imminent, and the communication was breaking down. And they were like, we need to get kid from the ward into ICU because we can't, if we keep coding here, we don't have the tools for it. And they were like, we'll make that decision when it comes to it. And they're like, we're at that decision. But it was so hard for them to see like how sick the kid was because of course of the hope. And it was really, really difficult to watch the conversation where they finally were ordered the DNAR, right? The do not attempt resuscitation. But it was such a meaningful thing to see because you can feel the pain of the child, you can feel the pain of the parents, and you can feel the pain of the palliative care physician.
The team.
Yeah, all being like frustrated by, of course, not wanting this to be the reality, and that hard difficulty of coming to terms with what reality is. But it was just a stunning film, and I bring it up because I feel like it's one thing for us to talk about it. It's another thing to live it. And of course, if you haven't lived something, one way to really tap into that lived experience is to really see it through the eyes of people who have lived it. And this is a beautiful example of that.
Yeah, no, I definitely need to watch it. It actually makes me think of the book, The Private Worlds of Dying Children. Have you read that?
No, I haven't. I should.
Yeah, I
writing
actually
it
just
down.
saw the author of that speak at the conference I was just at. And she's not a physician, but she writes about this pediatric oncology ward in the 70s where leukemia treatment was not great.
Right.
And so a lot of the children die.
Yeah.
And it really is from the perspective of some of the children. It's fascinating, right? It's fascinating, right? Like that one child is watching their friend, their, bedmate, roommate, walk into the procedure room, and they didn't, something happened and they died in there. And like, how does then this child has to like go into the procedure room again, right? So it's
right.
It's actually, The Private World of Dying Children. It's a good book.
So important. And it's, it's the reason, and I don't want to take up because it's like, oh, I don't want to talk about myself, but it's the reason why to some extent. So my PhD that I'm working on right now, my dissertation is a qualitative. So it's much more about like richness and depth of interview than like a bunch of like, I don't have a high N, it's a low N. but it's a qualitative, phenomenological, existential investigation into the experience of electing for medical aid in dying, which is not legal across the US. It's legal in certain
Mm-hmm.
states. I live in California. We have the End of Life Act. And this is people who are opting to take a medication themselves to hasten the death that they already know is coming in an effort to ease their suffering. Most of the literature in existence is from the perspective of the caretakers, the parents, or the team, the providers. Very little literature is from the mouths of the people themselves. And of course, there are reasons for that. It is more difficult to do it this way. But I told myself, like, I want to hear why they are doing this, what their fears are, what their comfort level is, what's working, what do they think should be fixed within the system, what could make this whole process deeper and more meaningful and less painful and less stressful. Like, it's one thing to hear from the family, but the family never has a perfect empathic understanding of the perspective of the individual in the hot seat. And so talking to those people, and it sounds like, the private world of dying children, that's what this author did, is said, I want to hear it
she
from the
talked to the
kids.
children.
Yeah.
Yeah, she talked to the children, and it's fascinating, right? One of the, like, from the pediatric side, hearing from the siblings of children who have died is actually quite fascinating. And that's something that our team is looking into. There's lots of research on how the siblings found the whole experience, right? Of having a sibling with a serious illness and then passing away. And, for us, there's such a different relationship between parent and child, right? In pediatrics. So they're not only the caregivers, which is fascinating, but they were the parent, right? And I'll never forget this. One dad said to one of our team members, the day he stopped talking, when we had to sedate him because the pain was too bad, the day he stopped talking, the last day I heard his voice was the day that he was gone. Right? So conversations between a child and a parent, like the voice, right? Their voice, when their voice is gone, to that dad, that was it, right? So people's voices are important, right? They matter, right?
Oh man, yeah, it's this has been such an informative and deep and meaningful conversation, especially to broaden, the experience that I have with an older adult population into some of the parallels, but also some of the significant differences that we see with little kiddos who are facing this stuff head on. And of course, the family dynamics are very different at that stage, because most of my not all, but most of the people that I've worked with who have died didn't have parents anymore. They had already seen their parents go on. Some of them did have parents, though, so there were caretakers present. So it really does run the gamut. And of course, we didn't even talk about medical aid in dying. We didn't talk about voluntarily stopping eating and drinking. We didn't talk about any of the palliative sedation, any of the ways that, like, people do die. We didn't get into the nitty gritty, which I want people to get into. I want people to approach this and learn about it and dip their toe into this, so that, I always say, and I am not the one who came up with this. I mean, Carl Sagan in The Demon Haunted World talked about this, but I think of, death as something scary and dusty in the attic that you don't want to approach when the lights are off. But the minute you shine a flashlight, you're like, oh, it's just a dress form, right? Like, oh, okay. And it's still something we're never going to know, but the more light we bathe it with, this less scary it will become.
Totally. And, pediatric deaths are low frequency, high impact events is sort of how we talk about them. But pediatric palliative care is exactly like that, right? Scary if you don't know what it is, but actually when people do engage with us, it's I've never heard a family say, once we started to get to know you guys, we didn't want to. They all say, I wish we had come to you sooner. And so, if anyone who's listening or anyone who would like to know more about palliative care, Canuck Place, like, we were the first pediatric hospice in North America.
Oh, wow.
Yeah, it's a really beautiful story. Like, it was actually an oncology nurse
Oh, of
who
course it
had
was. I
visited the
love that.
UK,
Yeah.
right? Who visited the UK in the early 90s and came back um, from the pediatric hospices in the UK. I'm blanking on the name, and she was like, "Why don't we have this here?" Right? She's an oncology nurse, and she actually kind of got to know the hockey team here are the Canucks,
Hmm.
and she was just at an event with the head of the Canucks, and it all came to about that there was this old home in the middle of this very fancy area, um, who the owner, this little old lady who died, in her will, she didn't have family, and she left it to um, the city of Vancouver to be put to good use.
Oh, I love
And
that.
all these dots connected, and they made it into Canuck Place Children's Hospice. Um, and so it's fascinating, right? Because it's this amazing place full of life and love, and but it's so scary to some people. So, I always say, if you ever want to come visit the house, if you ever want to know more about us, like, just Google Connect Place, look it up, email us. Like, we love sharing what we do, right? Like, we're passionate about it. We love to share the happy stories and also the sad ones, right? But yeah, if anyone wants to, please look me up, look us up. We're happy to talk about who we are. We love what we do, and I think I'm one of the most privileged people in medicine, that I get to work in this amazing, you know, setting where I can really care for human beings rather than patients. And so I am always happy to talk to people about how we can change things, right? How we can make things better for all people. So
Absolutely. Oh
yeah.
gosh, I'm just so grateful for the work that you do, for the dedication that you have, for your willingness to open up and to share with us. I hope that you and I can stay in touch in the future, maybe even collaborate once I'm out of my training and into the real world and no
Absolutely.
longer under supervision. But I got to ask you, Natasha. I know I've kept you longer than I even said that I would, but
No problem.
I
No
close
problem.
every episode by asking my guests the same two questions. And I want to keep it as open as I do with all of my guests, because I always say it can be in whatever context is relevant to you. It can be like more global or even like cosmic, or it can be kind of closer to home, personal, familial, or within your kind of vocational area. And you may have already touched on this if you want to talk about it within the context of your work. But I always ask my guests, when you think about the future, tell us two things. The first one is, what is the thing that keeps you up at night, that you're most concerned about, worried about? You actually used that term earlier, keep me up at night.
Oh yeah.
But the things that like really do make you worried and maybe even a little bit pessimistic or cynical. And then, of course, to end on a more positive note, where are you finding your hope and your optimism? So again, you don't have to talk about pediatric palliative if you don't want to, in whatever context is relevant. But I would love to hear those two kind of sides of the coin for you.
Yeah. Yeah, definitely. The things that keep me up at night are a couple things other than what I already talked about. One of them is really the environmental impact of what we're doing to our planet. Um, it 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 makes me emotional when I think about it, because it impacts. Again, I care for children, and that's one of my passions, and it impacts all of us, right? What we're doing to the planet, and how that trickles down to everything we do, right? You know, all these natural disasters, um, children need palliative care, right? Children are dying from all sorts of things, not just cancer. They're dying from natural disasters. They're dying from war, and all of those things. It's always a similar theme for me. It's suffering and untreated suffering. I think it all kind of comes back to that theme for me. And I'm one of those people that I can't watch an animal suffer on TV or a show. And it's all of it's global warming. It's the kind of context that our world is in right now. There's so much hate. There's so much, everybody, it just feels like there's a lack of compassion going on in life right now. And it makes me really scared, and it makes me really sad that there are so many downfall effects of that, right? A lack of compassion causes suffering, I think anyway. And so how do we fix that, right? Like, how do we come back to understanding each other? How do we come back to common goals of saving our planet, of, you know, inclusivity, of helping each other, right? I feel like everybody's out for themselves right now. There's individualistic approaches to living right now, and it does keep me awake. And I think the theme is suffering, right? We're all the world is suffering in different ways. But on the same note, you know, what gives me hope? What gives me hope truly is I see families and parents and people go through unimaginable things, you know, things I can't even explain, right? Let alone the death of a child, which is unimaginable to most of the population. But on top of that, right, you know, it's not unheard of for me to hear a family taking care of their dying child, but then grandma dies the same day, or, you know, they lose their job, or like these families go through unimaginable things and they come out of it with humility, with grace, with compassion. They carry compassion and they carry love despite all of the things that they've been through. The colleagues I work with carry 25 years of suffering that they witness on their shoulders, and they still have hope, right? So I think for me, being able to see families and people, humans go through this, it gives me hope. It gives me hope that despite all the bad stuff that's happening in the world, despite everyone kind of feeling like they're alone and we're against each other, day to day, I get to see the good in people. I get to see the resilience. I get to see the humility. I get to see people reach out their hand to one another, whether it's in medicine or not. And I think I still have hope. I have hope that human beings are good and they're there to help each other. So I think for me, it's kind of twofold, right? I see both sides, and that's what actually keeps me going. Is I'm like, oh my God, like how do they do this day to day, right? Like how does this family wake up and come with a smile on their face, regardless of what's going on around them, right? People are resilient. Human
But
beings.
What's funny is people are saying that about you too. People are saying, how do you get up and go to work and do this every day? And it's because they don't see the beauty and they don't see the depth and the meaning. And like, gosh, I and of course my job is different, but there's some overlaps. And I'm always like, I couldn't do anything different. How could I not do this every day?
Yeah. Families always ask me like, oh, how do you, which is crazy to me because their child's dying. And they're like, how do you do this every day? And I'm like, well, truthfully, because I get to meet people like you, right? Like they give me strength. They give me, if they can be resilient through this, we all should be able to, right? So it's really, it's a privilege. It's a privilege and an honor to be let in to such private moments and families, it's intimate, right? It's an intimate type of care that you get to provide. And you get to see so much more than just the patient and the parent. You get to see people day to day living their lives as best they can. And I think that's simplistically, I think that's what I have hoped for. Yeah, totally.
Natasha, I have to say, I knew I was right when I said we got to get you on the show. I'm so glad that we had this chat. It was so meaningful. It was so validating. It was so just loving. And I hope that for everybody listening, there was a little bit of insight, enlightenment, some opening of their hearts as they heard about these just incredible stories and the really, really important work that you do. So not only thank you for being here, but thank you for doing what you do.
Thank you so much for having me. I'm not a podcaster, so I'm really grateful. I'm really grateful that you gave us the opportunity and I got to speak about my life and my colleagues and the privilege I have of working with children and families. So I do really appreciate being asked to be on here, and I'm excited. I hope people reach out. Please do if you'd like to hear more about me and my job or Canuck Place.
Absolutely. And everyone listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.